Hello and welcome to this year's Trails Competition Finale Pitch Event. I am Laura Sconyers, the program manager here at Cambia Grove. At Cambia Grove, we serve as a catalyst to transform healthcare towards a more person-focused and economically sustainable system. And we do this through collaboration with the 5 points of healthcare, which includes patients, payers, providers, policymakers, and purchasers, as well as other aligned stakeholders and innovators within the ecosystem. Our goal is to drive transformation by optimizing 3 key elements of the healthcare ecosystem: infrastructure, incentives, and culture. And as part of this work, Cambia Grove identified an opportunity to create direct pathways between startups and the traditional healthcare system to help foster a culture of innovation. We developed the concept behind the Trails competition to provide promising startups with the real-world application and feedback that's necessary for these solutions to succeed. Winners of the Trails competition will gain a better understanding of how their products can be developed and scaled to address critical challenges in healthcare. This year's competition sought solutions to challenges in the behavioral health space. To address this current and crucial need, we structured the competition in a new and different way that would allow for even more real-world access and exposure for our finalists. The top 5 finalists that you'll hear from today were selected from a competitive pool of applicants after undergoing 2 rounds of online judging with experts representing the 5 points of healthcare with specific expertise in behavioral health, strategy, and investment. Over the past couple of weeks, the top 5 had completed a tour of the 5 points of healthcare, gathering real-world insights from experts at these leading organizations. Today, the finalists are here in the final stage of the competition, and they're pitching for the grand prize. This year's grand prize winner will engage in a series of informational interviews and workshops with strategy, clinical, operational, and venture groups with our prize partners at both Providence and Multicare. We are so thrilled to welcome our finalists here today to hear about their solutions and the impacts that they'll have on addressing challenges in behavioral health, and to our judges for being here and raising important questions, providing feedback to these solutions that will help them advance to market. So during this event, each company will have 5 minutes to pitch their solution, followed by 10 minutes of Q&A from our panel of judges. At the conclusion of the pitches, we will take a brief moment to tally all of our scores, and then we will announce our grand prize winner. So to kick off today's event, I would like to invite Samantha Clark and Julie McComish to the stage. Samantha and Julie have worked alongside Cambia Grove throughout this year's competition, from helping develop the concept starting last summer, throughout the fall, and helping connect us to various experts across the ecosystem. And they will be spearheading the grand prize package. So we're so excited to have you both join today and participate as judges during today's event. So Samantha and Julie, oh my goodness, my screen. Please join me on stage just for a quick moment and share with us what you're most excited about for this year's competition and prize. Samantha, would you like to go first, and then we'll hear from Julie?
No problem. Hello, everybody. I'm Samantha. I'm Assistant Vice President of Strategy and Business Development for MultiCare's Behavioral Health Network. I think I am most excited today to just listen to what ideas you have and get inspired by you. I was once a social worker, and living in healthcare, especially in a large healthcare system, I've learned to really appreciate the regulation and the risk and the safety, quality assurance that we have. And in my role in strategy and business development, have learned to appreciate just how cumbersome navigating all of those things can be in terms of change and innovation. And it's your work, it's your ideas that really drives and inspires individuals like myself who are living in the day-to-day of operations. And it's minds like yours and passions like yours that's going to make our healthcare systems even better. And so I'm excited just to feel your passion, feel your spark, listen to your ideas, and hopefully provide support in the future to make your ideas a reality.
Wonderful. Thank you, Samantha. Julie.
So well said, Samantha.
Very.
It's so nice to be here with all of you. My name's Julie McComish, and I am the Director of Mental Health Strategy for Providence. We're a large health system across the West Coast, and previously worked in our digital innovation group. So it's been fun to participate in this work while wearing both hats, coming from the mental health side as well as the digital innovation side. I echo what Samantha has to say in terms of just really wanting to learn about what ideas folks have. I am preaching to the choir, I think, when we highlight just how much need there is right now, and what a gap there is in our ability to provide services, with high quality to all the patients who need it, all of the community members who need it. And, we can continue working on this, but we can't do it alone. We really need to be partnering with innovators outside of the healthcare system, innovators inside the healthcare system. We're doing work to try and leverage our employee ideas, and there's just so much need. And so I love these opportunities to collaborate. As Samantha mentioned, it is really confusing to be in the heart of a huge healthcare system. And so, bringing some of those insights to those of you who might be able to tackle some of the biggest challenges we're facing is really exciting. And I'm looking forward to hearing what all of you have come up with, and hopefully as part of the prize package, getting to interact and have some further exploratory conversations with the winner.
Thank you, Julie and Samantha, both for joining and for, again, guiding this effort. We're so excited that we're here. This is the big thing. So now I would like to bring our other judges to the stage for a brief introduction. So if you all will join us on video, and let's see, there we go. Great. So let's just do a quick introduction, and an opportunity for you to introduce yourself to our audience, a bit about, who you are, where you work, and maybe what your expertise is. And let's start with Omer.
Awesome. Thanks, Laura. So Omer Ahmed, I'm on the investment team at Equal Health Ventures. We're a strategic investment fund that invests on behalf of a number of Blue Cross health insurance plans, including Cambia or Regence Blue Cross Blue Shield. We've been spending quite a bit of time in behavioral health. Given what Julie and Samantha said, the challenges in this space are extreme but not insurmountable. And so thinking not just as ourselves, but also working with a number of our partners, thinking about what are businesses that drive and address things like, workforce challenges within behavioral health, things like the access gap, is something that we've been spending a lot of time on. And I'm excited to see the approaches of the 5 finalists today.
Great. Thank you. It's great to have you with us. Gabe.
Hello, everyone. My name is Gabe Howard, and I live with bipolar disorder. So I'm coming at this from the lived experience side, or the patient side, or the consumer side, or the peer side. It just depends on where you live, what I'm called. But I am a person who lives with bipolar disorder, and I'm glad to be here. I'm also the host of the Inside Mental Health podcast over on Healthline Media, and it's really awesome because I get to talk to people from all walks of life and from all educational levels, from Jillian Michaels to the president of the National Institute of Mental Health, and literally everybody in between. So I feel that I get a good, solid foundation of behavioral health, mental illness, and what challenges are being faced all over the country from multiple perspectives. And even with all that, there's just so much unknown and so much to learn. So I appreciate the opportunity to be here, and that's who I am.
Thank you, Gabe. John.
Good morning, everyone. My name is John Kim. I'm the Executive Director at Pacific Hospital Preservation and Development Authority, where we seek to eliminate disparities in health outcomes and access to healthcare. Specifically in the Seattle-King County area. And we do that by stewarding landmark property and using revenues generated from lease activity to grant into community-based organizations who are serving specific populations through a competitive grant process. We're very much interested in increasing our impact by doing a better job of sharing learned experience from our grantees, because they've seen it all. And this notion that we are ill-equipped to deal with the wave of behavioral health concerns that are not just already here, but that are building like a tsunami, means that we have to be thoughtful about what are the products and services and how do we deploy them in ways that can take advantage of what we've seen and learned over the last 2 years regarding access and cost and quality. So I'm so excited to hear the pitches. We've got a lot of work to do, so thank you.
Great, thank you, John. And Dr. Polo.
Great, thank you very much, Laura. So I'm Dr. Jim Polo. I am an executive medical director at Regents. I'm actually a psychiatrist, child and adolescent, as well as adult, and have practiced for many years and still somewhat active in a small capacity. For the last 4 years at Regents, I have been involved in our behavioral health approach from a strategic perspective, and I serve on a number of national committees with BCBSA and AHIP that focus specifically on exactly what John just talked about: access, cost, and quality. For the last 4 years, I've spent a tremendous amount of time meeting with CEOs and CMOs of many startups, some who have been quite successful and some less so, trying to figure out what's the right way to kind of solve for the various challenges that we have. And the reason why I shape it that way in terms of what I'm saying is because, just like John said, we have a tsunami of behavioral health challenges that has been coming for a long time, well before the pandemic. The pandemic has only actually made that worse. And we are now in a position where we simply can't train our way out of the problem. We can't create more providers. We can't train more physicians. We can't find more counselors. So we need to think innovatively on how we're going to use technology and digital applications to really kind of begin to help people. And it's a challenge that all of us need to be all in on, because it's happening everywhere, particularly in our disadvantaged communities. So I'm excited to hear what we're going to listen to today, and I'm looking forward to kind of like Samantha said earlier. I'm just excited about getting outside of the box thinking from people that are focused in one area, because we really need lots of solutions, not one, lots of solutions.
Absolutely. Well said. Thank you, Dr. Polo, and all of our judges for joining us today. I'm excited that your expertise will be contributing to the feedback that these solutions will receive. Okay, at this point, I will ask our judges to leave the virtual stage and ensure that you have your virtual pitch scorecard ready to go. And we will begin our pitch competition. So as a reminder, each team has 5 minutes to pitch, followed by 10 minutes of Q&A from our judges. Our judges will join the presenter on the stage after each pitch is complete. If we do have time during the Q&A, audience, you are more than welcome to submit questions to the presenters, and we will address those if we have time to do so. All right, without further ado, let's begin our pitches. So Capri is up first. Dr. Calvin McGinn, the founder and principal researcher, will join us on stage. Calvin, I'm ready to time it when you are.
Mm-hmm. Can you hear us? Can you hear me?
Yes, we can hear you.
Very good. Oh. Hi, I'm Calvin, Capri's co-founder. Last fall, we got a call from one of our sons. His friend Joey had overdosed. He was 27. Joey spent 14 years battling his addiction. Had he lived, he had a 50-50 chance of recovering, but odds are it would have taken him another 3 years or 17 years total to do so. No wonder we're losing so many. Every day I sit in rounds at Advocate Trinity Hospital here in Chicago, reviewing our patients. Guess what consumes the lion's share of our time? That's right, the ones with comorbid addictions. Whether we're treating their diabetes, swollen livers, or bad hearts, we all know we'll see them again next week or next month. We continue to track SUD-related deaths, undertreatment, and comorbid illnesses, but have yet to measure what might actually bring better outcomes. Even the American Society of Addiction Medicine's gold standard is based on a 40-year-old acute illness paradigm. For some reason, the rules for managing every other condition have never applied to addictions. That's because we can only improve what we can first measure. If we're managing anything else on the planet affecting 1 in 5, we routinely screen for it, and not with tools that only support episodic care. For Joey, they're the deadly kind. We need to identify more, treat them better, and recover them longer. Capri is a holistic, quantifiable, online addiction risk assessment. It integrates 5 validated screens into one disruptive digital tool that offers clinicians quick turnaround reporting, optimal level of care placement, targeted prevention, treatment, and measurable resilience progress, plus a wellness guide for those without a provider. It predicts risk, prevents onset, and promotes remissions with quality care tied to interval outcome gains. Based on decades of research, Capri's build model captures a lifetime of addiction risk with quantified measures. Capri is the first to measure risk against resilience gains, and by so doing, increases provider accountability while inviting longer and better outcomes. Clients take an online 15 to 30-minute self-referred or provider-mediated assessment and securely get a 2-page wellness plan to start managing their substance risk needs. Providers get detailed documentation from Capri's dashboard. 12,000 proprietary machine learning algorithms provide risk stratification with snapshots of 5 diagnostic timelines for nicotine, alcohol, opioids, and other drugs. Engagement, denial, and key readiness features are also front and center. Capri's data points can interface with digital health records across multiple medical systems to help track history, treatments, and progress, while optimizing continuity of addiction care and building a national research database. But Capri is far more than just a better assessment tool. It favors least restrictive environment with ongoing treatment guidance that tracks key social determinants of health improvements as well. Only a tool with such comprehensive support can move the health equity needle forward, first by improving access, and secondly, by increasing illness management parity. Through a wide range of strategic partnerships, so many can benefit from Capri's guidance. In the wake of the Great Resignation, for example, 86% of US employers have made behavioral health, stress, and burnout their top priority. Turns out 80% of those with substance problems are still working. With Capri's self-advocacy bridge to provider referrals, we can help employers save on average $8,500 for every employee with a year of recovery. With routine assessment, Capri can double who we identify, treat twice as many of them, and achieve 8 times the current recovery rate. The ROI includes volume-based licensing fees plus addiction treatment costs. The reimbursed CPT codes help incentivize primary care and ER provider buy-in. As for payers, Capri is about paying less for better care. And at illness parity, 25 times our current success rate, the savings are huge. We're pre-revenue with pending contracts, including a health management firm that's integrating Capri's wellness program into its benefits package to help improve EAP and primary care capture rates. We can already process 10,000 assessments per day. 3 pilot studies with 300 subjects have confirmed key risk and illness correlations. We have ongoing research with the Utah jail system, testing predictive outcome measures, and are also negotiating a pilot with Smart Recovery. We welcome partners to help further confirm Capri's value. And this is us. Doug says hi. And our talented and valued support team. Joey is just one more reminder, sad reminder of what the real cost of poor addiction care is. His loss only strengthens our resolve to do whatever it takes to improve how we assess, treat, and manage this deadly disease. Thanks for listening.
Thank you, Calvin. And I would like to invite our judges to the stage for Q&A.
Calvin, thank you so much for your presentation, for the work that you're doing. A question for you would be, what is the impact this actually has on a sort of patient's care journey? So let's say they take the assessment tool. What's the so what? How does that end up impacting their sort of trajectory, and how does that end up impacting outcomes overall?
Got it. So in the first place, they get to take it on their terms. So if they're not ready for a provider, they can actually go online and they can take this thing anonymously and get immediately a downloaded wellness plan that looks at what they shared and with branching questions comes up with exactly what kind of wellness plan matches them currently now, with recommendations for when they are ready to get a provider, what kinds of needs they would have. So that's the first step. Once they decide they want a provider, their zip code, the 3-digit code that keeps the HIPAA compliance so that they're still protected, there allows us to now refer them to a provider in their 3 zip code area so they can actually now get engaged. That provider, once they sign on to our platform, we have a dashboard that the provider gets to sign up for. They get then the results, but not just the 2-page summary we gave the person. They get a 5-page detailed report that includes all the documentation, all the diagnostics, and all the recommended trajectory and the level of care placement and initiation of medication, which medication, all those issues are addressed for the provider. So now you've got somebody who's not only got engaged themselves, but when they're ready and not before they're ready, they get a provider to meet with them in a context that allows so much more information to be present, to be shared and collaborated upon, to come up with a better treatment. Even in the assessment, we ask them what their preferred way of being treated if they had, for example, an opioid problem. Would they want replacement medication? Would they prefer to be off all medication? Would they want a bridging process? We ask that in the assessment too, so that the provider knows their preferences as well as the way they want to be talked to. We have, Myers-Briggs type information, so we can know if their communication style. So the provider has that information too. So already the journey has started with so much more data to actually give that journey a place to go that's more likely to go somewhere well. Once that journey started, interval assessments, we recommend 3-month intervals to track, for example, the relationship between resilience gains and now current risk and illness expression. Since we're doing illness on 5 timelines, we actually are looking at it across a long time, again, as a chronic illness. So by doing this, the provider now gets a long view of the process, and so does the person who's in recovery. So what this creates is so much more engagement. We also track engagement. We look at what's the next step in that engagement that's going to help us see that person is being more engaged. So at every step of the process, this tool is so much more than assessment. This tool is about management of care. And at each step with the interval reassessments, the provider and the person gets to review what they've learned, what resilience gains they've made, how that's impacted next.
Calvin, and am I hearing that this is free to the client?
Absolutely.
They take the assessment free, and then that gets your teeth into that life. And then that is where you're looking for opportunities then to connect them to care. And that is where the licensing occurs at that level.
Exactly. We wanted
what is my question is, what is the mechanism by which you get to that to the end client? And I'm thinking in particular of rural settings where the opioid addiction is gigantic and the population is dispersed and the access to technology is spotty. What is the plan to be able to get to that end user?
Right. Excellent question. So these people in rural America, where do they show up? They're going to show up in ERs. They're going to show up in primary care offices. Unfortunately, neither have been really trained, and I work in an ER setting, to really know what to do with these folks. So few are even ready to start MAT on them when they come in. But that's where they show up. So in these environments, we're going to be reaching out to create opportunities for providers to get part of this process too. They learn about it through clients who ask them to help them with it, or they learn about it through our outreach. We want marketing to support that. We're asking healthcare systems to help us get the word out so we can actually get the providers on the front lines. We can't solve this problem unless rural medicine is involved. Telehealth medicine is another part of it. So the hub and spoke approach, this kind of a tool is gold for a telehealth person to have all the information they have with a person they can't really be in the face-to-face in the room with. So
Calvin, let me ask a quick question.
Sure.
You're using the word provider very broadly, and I'm struggling with that. And the reason why I'm struggling with that is because 60% of the population has access to a primary care provider who's trained in family practice or internal medicine to actually treat them. But the population of folks that you're talking about aren't going to gain from their expertise to actually get treated. So in a rural community, in the absence of actual addiction-based expertise providers, how do you create increased access?
Great. Okay, you're right. We have, a few thousand addiction specialists across the country that are really trained to do this work. The needs are huge beyond that. So we need providers to raise their comfort level, at least approaching the problem. The U.S. Preventive Health Services Task Force recommended, even though all the screens weren't much good, they recommended every adult should be screened routinely anyway. So primary.
Oh, okay, but hold on, Calvin. Let me just interrupt you a second. Okay.
Sure.
The standards for screening and identifying folks with a potential substance use problem is fairly uniform across the country. Most family practitioners will do some kind of screening to identify. Okay. Sounds like your screening is much better, and it sounds like your screening also provides a treatment plan. But for the family practitioner, that treatment plan can't include treatment by them. They don't do counseling, they don't do group work, they don't do any of the services that would actually help somebody that's ready to recover. My question is, how does your solution indeed increase access to the providers they actually need?
It provides the access by, they're already going to see their provider at whatever rate they're going, right? Whatever rate that is, whoever comes in the door with these problems, they need somebody who's going to be able to understand what's really going on. And it's not just acute illnesses. It's actually a whole life that's in trouble long term. And so they need ways to change that life. And what we give the provider with the tool that they can pull up on their screen, that the person who comes in the door could already be working on and talk about, because they got this feedback online, is we're giving them specific resiliencies to work on based on what happened to them. So even if they're not able to engage them in all the illness stuff because they don't have addiction medicine backdrop, they are able to start them on more resilient. What's their environment, their home environment like? Are these people in safe places? Is their nutrition well? Are they getting exercise? All the things that are part of objective resiliencies that do impact this illness's progression. So primary care can be doing a number of things that aren't necessarily about the specialty they have in addiction care they don't have. Our tool starts them on a journey that looks at the first steps, all the parts of the picture that can be started. MAT can be initiated even in primary care, and we give them that input too.
What incentivizes primary care providers to engage? And the reason why I'm asking that question is the average primary care provider has about 10 or 15 minutes with their patient about once every 2 to 3 months. And there are certain requirements that they have to meet to actually get paid for that time. Many of the things that you've just described are germane to how you help somebody from a mental health perspective, but they are not billable for the primary care provider. So how do you engage the primary care providers to actually get invested enough to care beyond that 15-minute slot where they have to have a CPT code that they can get paid for?
Actually built into our assessment tool is CPT codes that actually do bill, that in fact look at E and M kinds of billings, add SBIRT to that, and add under SBIRT additional billings for specific screens that are billable also. There's a whole billing process that we found with Blue Cross Blue Shield. We work with them for 3 months that actually is billable. So it is reimbursable. It's much more efficient for them to have something in front of them that's already been filled out before the patient got in the room. So you're saving much more time. We're saving time. We're allowing reimbursement to be supported. And we're incentivizing these ways for primary care with more information to start to do something more than they're doing already.
Calvin, one last question from me.
Oh,
What has
John.
been done with regards to cultural competence and dealing with overcoming stigma and bias in many communities where there is a large amount of addiction occurring? And what about non-English speaking folks?
Okay, it's a great question. I don't want to cut it off, but we are at time.
Oh.
Calvin, if you want to respond via chat, that's totally fine, but we are
Thanks.
at time. So we will go on to our next one and invite Jake from Limbics to the stage.
Great. Great. Thank you, everybody. And thank you, Laura, for that introduction. And thank you, everybody, for tuning in to the Cambia Grows Trails competition. Very excited to be pitching to you today. And unfortunately, I'd like to start this conversation off on a little bit of a somber note, discussing an issue that I think, unfortunately, many folks on this call are very acutely aware of from within their personal lives or from within the lives of their loved ones. And that really is the growing mental health crisis in the United States. And really specifically among adolescents, where we're seeing rampant levels of depression that really demonstrate that there is a health crisis in this area. In 2020, we saw record levels of adolescents experiencing a depressive episode, with over 4 million adolescents in that year experiencing depressive episodes, an over 50% increase since COVID. Unfortunately, that was met by low treatment rates, often driven by limited treatment options in the primary care setting, and a dearth of pediatric mental health specialists to really address those access needs. And as a result, and as a consequence and a contributing factor to this, what we have seen is that suicide is the #2 cause of death for US teens in the United States. That's a trend that we're looking to reverse. And it's also a trend that is getting nationwide and legislative recognition, with the Surgeon General coming out with an advisory in December 2021, last year, mentioning how we are in a crisis and we need to find solutions to support the mental health challenges in children, adolescents, and young adults that are incredibly widespread. And that's exactly why we developed Limbics. And at Limbics, we're developing a pipeline of prescription digital therapeutics specifically for adolescent mental health disorders. Prescription digital therapeutics are differentiated clinically and in a product design perspective from other mental health or wellness apps that you might find in the App Store for a few reasons. One is that our products undergo rigorous nationwide randomized controlled trials to demonstrate safety and efficacy. Second, we submit that data to the FDA in order to receive FDA clearance for our offerings. And lastly, they're meant to be prescribed by a healthcare provider, very similar to a medication. For patients, we're really looking to develop digital solutions that improve access to affordable and evidence-based mental health treatment. For providers, we're looking to develop safe, clinically validated digital treatments that they can trust, especially as they're in the primary care setting in this space. There really is a lack of options, especially when it comes to the dearth of specialists and medications that, while they do work and are used in some portion of the population, are not seen as effective in the adolescent population. And for health plans and employers, we're really trying to create cost-effective tools to offer patients and caregivers that can improve general population health and reduce long-term costs. Our first product in digital therapeutic in the entire pipeline that we're looking to grow out is SparkRx. And SparkRx is an evidence-based digital therapeutic intervention for patients aged 13 to 22 with symptoms of depression. One thing that's really important to note about SparkRx is that it is a self-guided program. We are not a services business, and it's a pure software program where patients are able to access the program on their phone, complete the program at their own pace over a 5 to 7 week period. And the core components of the program are based in cognitive behavioral therapy and more specifically behavioral activation. The curriculum was developed alongside experts at the National Mental Health Innovation Center and experts from Stanford, and perhaps even more importantly, alongside a teen advisory council. Really the best source of information we can get for developing a product like this, to make sure that our product is designed by teens, for teens, to meet the unique needs that they have within digital health throughout their patient journey. We've been incredibly excited and happy about the progress and traction that we've made to date and look to drive that forward over the next few years. We've raised 31 million to date up through a Series A2 from top investors in the space. We've had 220 patients participate in our nationwide randomized controlled trials that have shown clinically meaningful reduction in the symptoms of depression. We've completed or have ongoing 2+ pilots with top national health plans and IDNs, and 4 partnerships with top pediatric academic medical centers in the US, really trying to drive quality improvement and pilot efforts in using digital health technology. And I think really most importantly here, we launched back in October 2021 under FDA discretionary enforcement to really serve as a resource during the pandemic at no cost. And our product is being used in the real world by patients and providers every day. I think, as all startups, our team is our greatest asset. We've amassed over 40+ cross-functional employees who are led by entrepreneurs who have had great success in Silicon Valley, scaling up consumer-grade digital products. And they've surrounded themselves by top talent from top health plans, academic medical centers, research universities, who are able to combine that ability to create top-notch software with high clinical rigor and the ability to demonstrate strong evidence for our solutions. And we're very, very excited and looking forward to working with more partners in this space. We understand that, this is a marathon. It's not a sprint. There's a lot of challenges to work through, regardless of the stakeholder that we're working through. And we look forward to addressing those challenges head on with you all.
Thank
And
you.
with that,
Jake.
I'd like to open it up to questions for you all.
While everyone else is coming in, I'll jump in. I know one of the biggest issues that we've seen with these types of digital therapeutics is being able to get the patients engaged enough that they actually do enough with the program that they demonstrate results. And the reality as you execute and implement this is very different than a lot of the actual research that's happening. So can you talk about how or developing engagement, what your engagement framework is, how you've been able to demonstrate continued engagement throughout the course of the treatment, and what those results look like?
Yeah, absolutely. I think the cornerstone of that from the first perspective is that the product is designed to be recommended by a provider, which definitely creates a certain level of engagement and trust in Therapeutic Alliance that might go beyond an app someone might develop, download on the App Store. But kind of alluding back to that Teen Advisory Council, we knew that this was going to be an issue that we wanted to focus on front and center. So we really designed the product to try to be as engaging as possible for that audience, including design elements, a bit of gamification, but not enough where they're just sitting on their phones all day and playing a game. That's not the idea here. And we've also included notifications within the app to make sure that they're completing their weekly assessments and staying engaged with treatment. We also have a provider portal that we're going to be launching to really further increase that connection between the provider and the patient and hopefully further drive that Therapeutic Alliance.
Can you talk a little bit to how it's, in the trials that what percentage of patients are actually sticking with it? I hear you. I've run these programs with that are provider prescribed. It's really challenging. And one of the number one predictors that we found in terms of engagement rates was actually how the coach was involved. And so when you don't have a service component, that really takes away one of the engagement mechanisms. So, what percentage are actually sticking with the course of treatment?
Yeah, that's a great question. And definitely we do. So it's a 5-level program. Level 3 is the level where we actually have the most, involvement actually within the app. It requires patients to complete activities outside the app that they scheduled, come back to those activities. And we do see that as a bit of a cliff and a point where sometimes they don't fall through the rest of the treatment. But we have seen impressive engagement above the bar of standard digital therapies in the space up to that level. And one thing that we've seen as very promising is that those patients who do complete the program as prescribed are seeing incredible results, especially relative to the control. not going to sit here and say that engagement is something that we're not working on and not thinking about. It's going to be one of our top focuses, but I think our consumer background and ability to create top-notch software is going to help us drive progress with that moving forward.
So following on some of Julie's questions, I think we've seen the same thing, right? Which is, hey, on paper, it sounds great. It's a lot of these prescription digital therapeutics. But the question comes down to actual getting engagement and actually seeing whether real world evidence mirrors what you've done in your RCT. Any color you can provide on any RWE generation you guys have started doing so far, any evidence you've gotten from that analysis that you'd be able to share?
Yeah, absolutely. So, and a couple of things on the engagement piece. Real world engagement, I think similar to medications, digital health is definitely lower than the trials that we've conducted for a variety of reasons that you've all alluded to. But what we have seen that is very, very promising is clinically meaningful results despite those engagement challenges for those that really do push through the program. So despite the engagement challenges in the real world that we're still working through and we're going to create a robust model to support, we are seeing those clinical enhancements very similar actually to our randomized controlled trials, which is really promising for us. And it lets us know that we really have to focus on that engagement piece to really drive and sustain those outcomes for all users of the platform.
Jake, can you speak a little bit to how Limbics would help with behavioral health workforce shortage and the cost structure for either the patient or the provider group that would be using this?
Yep. So as for the cost structure point up front, we have launched under FDA discretionary enforcement at no cost. So until that discretionary enforcement period ends and we submit to the FDA, it's available for free to patients as of now. Actually, can you repeat the first part of your question, please? I apologize.
I'm just looking for, when you scale, what's the cost to patients, what's the cost to providers, and then how does that translate into scalability for workforce?
Yeah, so the great thing about the scalability for the workforce piece is that aside from the first component of the provider recommending or eventually prescribing the product, it's self-guided. The patient completes it at their own pace. It doesn't require telehealth visits from scarce pediatric specialists to join actively on the call. It's part of an adjunct to the ongoing patient journey, and it would fit very well in a telehealth setting. But I think it really gets at that access and shortage issue by being a self-guided, pure software program that allows patients to engage and guide their treatment without the ongoing engagement with a healthcare provider.
Jake?
Yeah.
So the science behind cognitive behavioral therapy is well established. I like your platform approach. How does your solution account for individuals that maybe enter into the solution where their needs are beyond CBT? They're not in that mild and somewhat moderate category, that they're really at risk. How does your solution either provide a stopgap to make sure those folks are served or redirected elsewhere?
Yeah, absolutely. So one thing to lead with is that this product is definitely designed more for the mild to moderate cases. We don't suggest that providers recommend this to patients who have active suicidal intent. That's not the idea for this, but we also know that the journey of a patient through depression has its ups and downs, and they might be given the product one day and the next they have suicidal intent. Safety is top of mind for us, and it's something we're always thinking about. There's crisis resources always available within the app that are available at the touch of the button. And we also have real-time monitoring of the inputs that patients put into the app that make sure if there is any harmful language detected, those resources pop up and make sure that the patient knows who to reach out to. And as we kind of continue to further develop that provider portal, I think increasing more of those safety measures and outreach when it's needed will be further enhanced. I think that brings in another range of challenges around provider liability and things that we're really thinking through. But we know how important it is, and safety really is top of mind for the population.
When it comes to operational use, I think that everyone who's used an electronic health record on this call can say that the fewer clicks, the better. As a behavioral health clinician, how are you considering the daily use of having to log in and out of portals, in and out of the EHR, getting clinical information from your portal to the EHR for the behavioral health clinician?
Yeah, as someone, I was on the innovation team at Boston Children's before, and it was an issue that came top of mind for us at all times. To date, we don't have direct EHR integration with our portal. It's actually recently launched under beta. However, it's top priority for us. And if we're able to identify a partner that wants to go down that route and really implement the solution, we have a team of tech specialists from actually top health plans who are very acutely aware of the steps needed to address those challenges.
We have about 45 seconds left. So if there's one final question, we have time for that.
There's a lot of CCBT solutions on the market right now, many of whom have adolescent-specific programs. Why is yours different than those that are already out there?
Yeah, absolutely. And it's a question that comes up often. I really think it is that prescription digital therapeutics label. We're really trying to be differentiated by conducting those rigorous nationwide controlled trials that would be submitted to the FDA and be FDA cleared. We really hope that this drives provider confidence in our solutions, their willingness to actually try it in their patient populations, and perhaps not just recommend an app that could be downloaded on the App Store that might have some level of evidence, but not the level of rigor that might be demonstrated through actually submitting to the FDA approval.
And have you gotten any traction from payers that they're willing to actually reimburse for that if the FDA were to approve it?
We are in conversations and have conducted pilots with a national health plan and an IDN. Unfortunately, I can't disclose who. And we have seen early traction and a willingness to pay for the products based on how the outcomes of the pilots, which are still ongoing in some scenarios.
Great. All right. Thank you, Jake. We are at time. Judges, I'm going to give you all just about a minute. I know there's some technological challenges happening on the back end with our score sheet, so we'll just take a minute and let Nolan help you all sort those out. And in the meantime, we will bring up JD from New Life, and we can go ahead and begin your screen share, JD, and I'll give you a cue when we'll start the pitch.
Sounds good. Can you hear me okay? First check. Okay, perfect.
Sure.
So you just let me know when we are ready to.
I think we're ready.
go.
I think that was all the delay we needed.
That was it, huh? All right. Okay, cool. So thanks for everyone for being here. My name is JD Mintz, the founder of New Life Virtual. We are a community healthcare platform that changes how we treat addiction. I'm sure you know that 100,000 people died from an overdose in the past 12 months. That's one human life every 5 minutes, and this is what we help solve. Outside of the pandemic, it's the #1 leading cause of accidental death in America. It's very personal to me. I almost died because the current treatment model didn't work, which is why I opened up treatment centers in 2014, realized what worked and what didn't, and set out to solve the problem. It's because the current treatment model doesn't work and isn't scalable. People don't know where to turn. Care is fragmented and transactional, which is why only 10% get help, leaving 90% to suffer. New Life is a community healthcare ecosystem that incorporates telebehavioral health with the 3 most important covenants of recovery: life integration, social support, and community. New Life transforms brick and mortar into patient-centric click and mortar because tremendous cost, limited access, and lack of necessity occur with residential care. There's a significant continuity gap between inpatient and outpatient care where we lose a lot of patients. There's little to no continuity between clinical care, peer coaching, and ongoing support groups. And New Life creates a straight and transparent path from referral through treatment and back into life for life. New Life is a modern approach to addiction treatment, capturing the best of digital health and in-person therapy to deliver care that meets people where they are. And this saves money. One example is wider access to medication-assisted treatment versus residential care, which can save more than $12,000 per patient per episode. Another is directly reducing it costs employers annually by getting people back to productive work faster. Much like Netflix provided us always-on, easy access to entertainment, we do the same for behavioral health care. New Life makes it easier for care providers to see more patients and stay in constant contact. Recovery is about building trust through positive outcomes. And we recognize the real rock stars are the doctors, clinicians, and coaches. From screenings to daily check-ins and community building, we automate time-consuming tasks, allowing these rock stars to be center stage, reaching more people and getting better results. But most importantly, New Life is for the patient and their loved ones. 90 days ago, Jacob completed his 6th treatment program and for the first time stayed on track because New Life gave him on-demand access to an extended virtual program, community resources, educational videos, and the ability to interact with peers. We're winning because we help providers grow, we increase health equity, and we improve profit margins, all while reducing payer costs by building a self-sustainable community around their services. We have just over $500,000 revenue in 2021 through a software development contract that helped us build our go-forward version after proving our MVP, and we're ready to grow. We have 6 paying treatment centers across 3 continents and project 60 in 2022, resulting in $2 million in ARR, then scaling to just under $100 million in 2026. The substance use disorder market is growing rapidly. There's over 16,000 facilities and 500,000 providers, but they're tapped out, serving 10% of this potential $300 billion market. As mentioned, more people need help. There's less people there to provide it, and this is where we come in. Our early product roadmap focused on building out the critical fundamentals of treatment schedule automation, care delivery, community, and assessments. And over the next 12 months, we'll be focused on New Life Match, which will leverage our behavior data, clinical assessment data, and outcome surveys to optimize practitioner, provider, and treatment pathway recommendations. The addiction market is relatively untapped compared to the pure mental health market, but there are some competitors going after it in different ways. But our model is allowing people to connect and engage and empowering existing providers to invite their patients and digitize their services. Model is a simple base monthly subscription fee, which can be scaled easily based on the number of practitioners, with an additional 10% fee for services booked via New Life Match. Our core leadership team consists of industry professionals, technology expertise, and clinical experts, and we have deep connections in the substance abuse vertical. Our advisory board is comprised of industry leaders, policy influencers, technology, content marketing, and clinical experts. It includes former healthcare system CEOs, insurance billing experts, and Obama's National LGBTQ Leadership Team co-chair. We're currently raising $1.5 million to scale our sales and marketing team, expedite product development, and further validate product market fit, because I don't want people to know where to turn or who to talk to. And we want to impact millions of lives globally by making recovery accessible and rewarding. Thank you.
Great, thank you, JD. Judges, please join me back on stage. Who has the first question?
I just want some clarification, JD, if that's okay. So
Yeah, absolutely.
my understanding is that New Life is a product that could be purchased and utilized by providers as a platform for reaching patients, or are you saying that you are also going to be providing all of the service, like the peer-to-peer recovery, like the addiction treatment, et cetera, and the connections to other levels of care through your platform?
Hey, great question. So initially, our focus is to go to providers to allow them to digitize and scale their services so that through that, we'll build our network of both, treatment center providers and independent practitioners to provide those services, along with, your peer coaches, and then, just the outside, support group world, your AAs, your NAs, your all your different smart recovery, all of that kind of built into the app and the social networking part of the platform.
JD, let me ask a question.
Absolutely.
Because it relates to Samantha's question. So once again, you're using providers very broadly.
Yep.
I'm thinking about how healthcare is practiced.
Yep.
What would incentivize a primary care provider to pay for your platform? I'm struggling to see what's in it for them that's an expense that would be worthwhile, because that's got to come out of their margin.
Yeah, so for the primary care physicians, as we mentioned before, a lot of that is I'm in there and I'm spending time like your 15 minutes every couple months with your primary care physician. It's a free platform for them to refer patients into this network where we're going to have vetted out treatment providers that they can introduce and refer to, and then understand and know where those treatment centers and addiction providers pick those patients up, take them through their levels of care so they can monitor and see that. And then when they re-enter back into their care, they understand. So it's that conduit between the primary care physicians or your healthcare systems that don't traditionally know what to do when their patients, have the, whether it's opiate use disorder or some other substance use disorder. It's that handoff mechanism and that bridge into that level of care.
So JD, just to clarify, I think my question is going the same spot. So I'm just going to say something and you just correct me if I'm wrong. You're effectively allowing the treatment facilities to go virtual, allow them to have all the tele-behavioral health work. You're not charging the primary care physician for anything. They would almost be a referral network for you, right? Am I understanding that right? Or
yeah, you're correct. So the app is available and open, to anyone on the network. But then it would also be a source for the primary care physicians in the healthcare systems to refer their patients and their families into to find that support and be able to monitor that journey. So it's just that connective tool that then also allows them to know that referral was picked up by the right person and by the right provider, and kind of understand what happened in that journey so that when they get them back, they at least know that they were taken care of.
And so on that note, can you just talk a little bit about the value proposition for the treatment facility and paying you some sort of fee? What's the sort of, so what for them?
Yeah, so great point. So a lot of obviously is with virtual care and with the changing, landscape, it's not just about what's happening in the sessions, it's about what's happening in between the sessions. It's about, the community and the cohort and keeping people connected. So I go from residential care, let's just say I go from detox to medication assisted treatment. Not only am I seeing the patients here while we're on this call here, but in between I can send them, periodic assessments or daily check-ins or feeling checks. But they can also stay in connection with the other people they're going through this cohort with. And part of the addiction and mental health model is about finding that connection with your tribe, other people that I can relate to that have either been through it, going through it, that are similar to me, that I can relate to. So keeping the connection to your patients. The one thing with addiction in care, different than medical care, is as someone in recovery, I could go through treatment, I could do fantastic. 30 days later, I have I reuse, and I don't always go back to that provider because they did a great job with me. Why? Because I'm ashamed. I feel bad that I feel like I failed them. But this allows those providers to stay in consistent contact, making that re-entry point easier, but also not always putting them back into that highest level of care, hopefully catching them sooner so that they can re-enter at a different kind of spot on that path. And they can keep those patients for life and longer than what they traditionally do. So it's a value proposition, more people on the front end and keeping people longer on the back end.
JD, what features of the program speak most strongly to the need for greater equity and for reaching populations that are not being served by the mainstream system currently?
Yeah, no, great question. I mean, obviously we talked about the stigma of treatment and, just the access and the cost. So one of the things that I did when I owned treatment centers a while back was we did a program where we went out and we were able to we were doing virtual care and full outpatient and group programming, back in 2017 and 2018. And obviously to run a virtual group, my costs are much different than it is to run a physical group, right? So we could provide care, providing care to 10 people in a group versus 15 people in a group. So we can lower our costs and we can extend our costs, into areas that, there's less, financial means and available. We can provide care to, allowing care providers, right? It's like, clinicians, therapists, counselors, peer coaches, of all these different type of, ethnicities and reach, the ability to reach people that are outside of, maybe their specific geographical area. So it lowers the barrier of care. It's, and it allows them to see people that are similar to them much easier.
So it addresses, go ahead.
No, how do you keep this whole thing from devolving into Facebook? I mean, you've talked about meeting with a lot of different people. I mean, what happens when everybody just starts fighting about politics?
Gabe, can I add to that?
Yeah.
Is it moderated?
I would love to add on to that. To Gabe's point, exactly. What we've seen with similar tools, whether it's something like Quartet that coordinates behavioral health referrals, or something like Unite Us, it's a closed loop social determinant of health referral portal. The onus is on the agency for that administrative burden of logging in, changing status, checking in. What is your plan for mitigating that risk so that it doesn't become a Facebook portal and that it doesn't become untenable in the administrative burden it takes to manage patient care through your tool?
Yeah, I mean, great, great question. I think it's fundamentally, it's where we start with our core values and the ability to not be about the amount of connections, but by, first of all, having very private, there's multiple levels of privacy available in our platform, number one. So communities can be very private communities. Communities can be a family community. It can be, a 10-person community. Your friend, your circle of influence can be, limited to, let's say, 5, right? Or 10. So it's the whole fundamental foundation of how we're built. I don't have all the answers to those long-term, questions. I mean, that's a big, broad, question. And as more activity becomes on the platform, there's absolutely going to be, issues that rise up from just the nature of the population base that we're serving. But we're starting from a place of multiple levels of privacy, multiple levels of anonymity, and multiple levels of specific communities that are built around what I want. So if I'm in the LGBTQ, or I'm into psychedelics, or this, there's these private areas that are monitored and specific to that particular groups, those particular cohorts. But I agree with you, that is an ongoing challenge that will be something that we need to deal with.
Great. Thank you, everyone. We've reached our time for Q&A. Thank you, JD, for your presentation. I'll give the judges just a moment to tally scores. In the meantime, I will invite Dr. Matthew Peters to the stage. And while we get set up, the judges can finish their final scoring.
Thanks, Laura. Just let me know when we're ready.
Okay, sounds good. All right, let's go ahead and get started.
Great, thanks, Laura. Good afternoon, everyone. My name is Dr. Matthew Peters, and I'm the Chief Medical Officer of Rose Health and an Associate Professor and practicing neuropsychiatrist at the Johns Hopkins University School of Medicine. The central tenets of Rose are simple. How can we use accessible yet sophisticated technology, combine it with a true human connection, and deliver the right mental health care to the right patient at the right time? At present, over 90 million Americans are reporting mental health concerns, and put simply, mental health specialists like myself will not be able to address this crisis alone. This is reflected in the fact that 85% of mental health concerns in the US are being managed by primary care providers. With mental health specialists focused on treatment of those with severe mental illness, individuals with mild to moderate depression, anxiety, and stress are largely seen within primary care. Since 2017, CMS has recognized this and created avenues for reimbursement through behavioral health integration, or BHI. However, when polled, only 10% of primary care providers feel prepared to treat patients with mental health disorders, and adoption of true BHI models has severely lagged the need. Creating a scalable, technology-driven solution for BHI can have an impact today. We have created a virtual platform that uses technology to make BHI within primary care scalable, no matter the size of the practice. We have both adult and adolescent versions of our platform. The Rose Health recipe for successful BHI is a combination of advanced technology and human connection. After a PCP office purchases Rose, they are provided with the virtual platform consisting of a patient-facing mobile application, a web-based provider dashboard, and a management portal for generation of key metrics. Electronic medical record integration makes billing for BHI seamless and efficient. Using the app, patients complete assessments, check-ins, and journal, and are continuously risk stratified with actionable data presented on the provider dashboard. Every patient using the Rose platform is provided with curated in-app self-help tools, including mindfulness techniques, live meditations, as well as videos and audio clips. These are recommended by the Rose algorithms. But this is only part of what makes Rose special. A Rose behavioral health specialist is assigned to each practice and works together with the practice providers to ensure successful patient engagement and interaction. The Rose specialist monitors the dashboard remotely, messages with patients, and communicates back to the primary care team, creating a scalable and billable BHI model that improves the quality of care delivered within and beyond the walls of the clinic. For high-risk patients, Rose has partnered with a leading care coordination team for 24/7 coaching and care connection. This human connection ensures accessibility for diverse populations, as recommendations are based on each patient's needs. Additionally, those without a smartphone can simply dial the care coordination team from any telephone line. To ensure success, we have partnered with a healthcare economist to create a financial model that brings a sizable return on investment to our customers. Our traction helps to show the scalability of the Rose platform. Primary care-based BHI is just the beginning. Our team has built the platform to be scalable into other market segments. Currently, we have expanded into risk-bearing entities and have future plans for an employee wellness offering. At present, we have over 35 primary care practices using the platform, and we have started a paid pilot with our first ACO. We will be conducting trials at 2 large health systems with our adolescent product this summer. Our current contractual ARR is $500,000. We credit much of our initial success to 2 things: our evidence-based approach and the team we have built. Before we launched our platform, we completed an IRB-approved randomized controlled trial that showed high adherence and satisfaction rates, as well as statistically significant improvements in symptoms of depression and anxiety. Just as importantly, we have seen real-world impact. 42% of patients using the Rose platform have shown clinically significant reductions in anxiety and depression scores after 30 days. The entire team at Rose has a reason for wanting to build this solution. Many of us are young, but we are fiercely devoted to what we are building at Rose. Kavi, Atif, and I have been building this solution from the beginning, and together have the expertise needed to continue our growth, especially with the dedicated team of advisors and staff, including Nicole Bradbury, who directs our board. Building a startup is not an easy road, but our team has a real opportunity to be part of the mental health solution. Lastly, we are doing our Series A raise now. This $7.5 million raise will allow us to continue growth into other market segments, conduct additional studies, and further refine the therapeutic content of our platform. We really can't wait to see what the future holds. Thank you.
Great, thank you. Judges, if you'll join us.
Matthew, do you have any issues with the practice of medicine across state lines?
Of course, yes.
So how do you Okay.
Yep. As we're scaling this out, we made a dedicated decision to do it regionally. So we have started in Florida and in Georgia, and the LCSWs that we use to do our monitoring are within that state. The care coordination group that we work with, however, they're licensed in 50 states, so they can really help us in whatever state we're in. And then as we grow this out, you're absolutely right. Our monitor is going to need to be licensed in those states for sure.
you talk a little bit about monitoring quality of this? So sorry, can you explain who's actually employed within your team? Are all your care coordinators plus all of the behavioral health specialists employed? And then can you talk about kind of quality management? One of the things that we've seen with some of these service providers as they scale, it can be challenging to make sure that you're getting the results. How are you working through that?
Yep. So the individuals that are employed by a subsidiary of Rose are the monitors. So yes, those individuals are part of the team. The care coordination group is one of the largest care coordination groups in the country. So they have their own quality improvement metrics that they use. And I've worked with them for almost 5 years now with a program at Hopkins and have been super impressed with them. So that's why we brought them on board. For our own care monitors, right now, I am the one that personally trains them. And the reason that we've done that is right now at the beginning, we need to make sure that this product is exactly what we want it to be as it's getting into people's hands. As we scale, the real goal of this would be that as we go into an ACO, we are able to train an individual at that ACO that would do the monitoring of the platform. So ideally, as practices, because what we're finding is primary care providers are interested in BHI. They don't know how to get it started, and they don't know who's going to do the monitoring. So our goal is to get them started, have our company do the monitoring, and then as they get more comfortable, they bring on their own individual that monitors it in-house. So that's our way of making this scalable and handing it back into the practice, because true BHI models, that the individuals really, the goal is for them to be on site.
Yeah, that's I really like that you brought up that point, because it's for Providence, this is something we're really thinking about with our models, is that we have some clinics that already have the licensed therapists, we have some clinics that have care coordinators and others that have no services, and it also helps scale. Can you talk about a little bit about the licensing and funding model? Who pays when, how sustainable that for small clinics? From what I've seen, primary care clinics, it's really hard to finance that upfront investment. So would love to learn.
Yep. So part of it is that we have to eat into our margins to do the right thing. And so that's what we've done as a company. We've made the decision that this can actually help people. And so part of it is us taking a cut on our margins. But the other part of it is that the solution at this point is out of the box enough that it's a very low cost setup fee on the front end. And then the providers pay a per provider fee. So let's say, depending on the size of the practice, let's say $500 a provider per month. They do not need to have that many patients onboarded and billing for BHI to make up for that money that they're putting out there. For ACOs, which is really an area that we've moved into now, that is why we made the investment to bring a healthcare economist in, so that they could actually take the data and be able to show this is what you might save in ED visits, this is what you might save in inpatient admissions. And they have created a model for us that we go to an ACO, they tell us about their patient population, we plug in the numbers, and it actually shows them what the potential cost saving is. So that was a really good investment on our part and has been really helpful. And for the ACOs, it's a per member per month fee.
Matthew, Matthew, I love the way that this makes the clinic better at doing what it's supposed to be doing, which is BHI. But for the extent that there's a huge population that's not coming into the clinic,
sure,
that suffers this issue, it's like, where's the opportunity to somehow make change to the system to bring in more of the people who need that kind of help?
Yeah, completely. And part of my answer to that is if we can properly get the people the care that are coming into the clinic, then those individuals that are out there in the community, resources can be committed to them. So, one of my goals in this is that I want every patient that walks through the door to see me to be the appropriate patient. I want them to be the person that needs my specialty care. And so part of it is if we can get people that do have the access, the right care at the right level, we open up resources for others. Now, the individuals that are out there in the community that, for example, are in a rural setting, if we can at least get them to see a provider one time, we really have made it that they just have to call a phone number to engage in care coordination with us. And, you know, John, I completely realize there are folks out there that aren't even able to do that. If we can make this part of the solution though, and everybody has the same, I think, positive outlook as we do, you can divert resources to help those individuals. And maybe that's the next product that we create after this one.
Good answer.
I've seen, you know, this is such a critical problem. And so there's a couple of, you know, I've seen a couple of solutions just in the last month that are trying to address this. Can you talk about why your model is different than, say, Concert or any of the others?
Sure. Yeah. A couple of things. So I didn't have time to go into depth about the technology that we have built into this, but we really have built algorithms that allow for early detection of decompensation. Other companies do something similar, but our algorithms are very special in the way that we've built them and the way that we've thought about them. And they actually do detect people early, including for our journaling process, we have a natural language processing algorithm that picks up on sentiment to even pick up in those entries, can we start seeing decompensations? And we're continuing to build that out with like passive data collection and the other things that people talk about as being helpful, but we're not going to put that into the platform until we study it and until we have an actual trial that shows that it's helpful. The second part is that we are and have remained committed to this having a human component to it. Other companies in the space have done that as well. I don't know any that have done both the engagement internally to have a monitor of the platform, as well as partnering with care coordination to have an end-to-end solution, because PCPs get hung up on how am I going to monitor this? And then how am I going to get people connected to care? And so we've created a solution that has both of those components. I don't know that anyone out there is doing that. They will once they see us doing it, but hopefully we're the first ones that have, you know, thought about that as a solution, because it takes a financial investment from our company to do that.
Mm-hmm. Very much so.
So Matt, I've got a question for you.
Sure.
The collaborative care model is difficult to implement for it to be payer specific. To implement the collaborative care model, you have to go all in for all of your patients, regardless of who the payer is. Sounds like your model could potentially allow payers to selectively, essentially fund a better approach for just their members. Am I understanding correctly?
Correct. Yeah. If you could help us tell payers that, yeah, that's exactly what this could do. I mean, and we've had those conversations and we've started to. One of the ways that behavioral health integrate, and you've probably noticed I've been very careful to say behavioral health integration, not collaborative care models, because that is a very separate.
Yes, you have.
And we're looking into that, and we'd love to do that, and we've connected with groups that are doing it. The PCPs have to be very incentivized to do that, and they need to be very ready to do that, which maybe we'll get there with some of our groups. What would be very successful for a payer is to view this as an offering that can go out to its members, whether it's individuals that have already been identified, or we have the ability to look through the EHR for a patient population and find the different ICD codes that would be relevant and that could roll this platform out. I want it to be used for both monitoring so that people don't decompensate and for those people that are currently struggling. So I think if we can help payers see that it's a pretty big part of their population, you know, not even to speak of the influence that mental health conditions have on physical health, which, you know, is obviously a huge topic for them.
I know we're running short on time, but Matthew, can you speak quickly to how you're recruiting for diversity, equity, and inclusion?
Mm-hmm. Yeah.
Okay. Well,
sorry.
Me again. We are out of time,
Yeah.
But yes, Matthew, if you would like to answer the chat, please feel free to do so.
And Samantha, thanks for asking that. I'll get you an answer.
Perfect. All right, judges, I will give you a little bit longer than I did last time to get your scores in. In the meantime, we'll bring up our final finalist, Patrick. There you are, Patrick. Great. So we'll just, if you want to go ahead and begin sharing your screen, I will let our judges have a moment to input their scores in our scorecard. before we
Sounds
get
great.
started.
Oh, hold on.
Great, we can see that. We'll do just about 15 more seconds and I'll give you a cue when it's time to start.
Sounds great.
All right, Patrick, let's hear the pitch.
Okay, wonderful. Great. Thanks so much for the invitation, Cambia Grove, for being here. Today, I'm going to be talking about an mHealth solution for alcohol addiction called Step Away that we have created. Is there a need for something like Step Away? Well, obviously, we've got 25 million Americans struggling with alcohol addiction, and we're only reaching about 10% of that group with our current treatments, largely because of stigma, admitting to others of having an alcohol addiction, and of course, treatment accessibility and affordability. Now, these numbers were bad before COVID-19, but they've gotten quite a lot worse. We've noticed a 30% increase in heavy drinking across the population, 25% increase in alcohol-related problems, and that has been worse for women as well. So what does Step Away do? Well, Step Away, first of all, enhances awareness of alcohol as a problem and helps develop motivation to make a change. It helps a user set a goal and monitor progress on a day-to-day basis. It helps them manage triggers using in-the-moment tools and develop new coping strategies and non-drinking activities. One example of one of our steps is the awareness step, and it really is getting people focused in on how much are you really drinking, which is a big surprise for people, the costs and consequences of drinking, and also their personalized triggers for drinking. Another important module for us is goal setting. We're helping users set a goal, and that can be either a moderation or an abstinence goal. We are helping them track progress on a day-to-day basis and provide excellent feedback. We also provide daily nudges through tailored messages based on their goal selection. Another important element of Step Away is the cravings module, and that is helping people to manage a craving for alcohol, which people have when they make a change to their heavy drinking. And it helps them to learn specific coping strategies for their specific types of cravings. It's also available 24/7. Anytime they need help, they can just click on a button. What is unique about Step Away? Well, Step Away has a moderation platform. It supports sobriety, yet we're really focused on moderation and harm reduction. 80% of the people who download Step Away choose the moderation route. It also allows sharing of progress with a personalized support group. Importantly, Step Away is increasing reach of alcohol treatment to groups with very low addiction treatment rates. For instance, we see more women downloading Step Away than men, and that's actually the opposite of what happens in traditional treatment. We also have proven efficacy through clinical trials funded by the NIH and the VA. What have our effectiveness trials shown us? Well, across 4 different trials, we have seen hazardous drinking dropping between 45 and 65%. We noticed that 50% of participants are still engaged with Step Away at 6 months, which is an excellent finding in the mHealth world. The app also moves users into an action phase of changing their drinking. Where are we now? Well, we've received over $3 million in grant funding to support 4 different clinical trials. Those have been through Palo Alto VA, Seattle VA, University of Auckland, and University of Alaska. We've had 4 different app releases. We're releasing another one this month, more than 10,000 signed up users. One of the things we notice is that if people purchase a subscription from us, 80% of them are retained at 1 month. So the solution has good stickiness. Our current organizational partners are Recover Alaska, Alaska Behavioral Health, and the Veterans Administration. Speaking of the VA, we have created a specific app for them called Stand Down, Think Before You Drink. It was developed in collaboration with VA psychologists and veterans, and it's been customized to reflect veteran culture and access to VA support. We have a large-scale multi-site VA clinical trial beginning in 2022 that was funded last year. This trial looks at Stand stand down in the context of primary care settings, which I think is a great opportunity. So we have a good opportunity to launch into VA services. Where are we headed now? Well, we really want to develop more organizational partnerships. One of those partnerships that is emerging is with Kaiser Permanente Northern California. We have a recent NIH grant with them and UCSF to focus on implementing Step Away into Kaiser's services and testing their efficacy. We also obviously want to launch into VA services and further develop our artificial intelligence to recognize milestones and warn of a relapse. Our team is myself and Marco Dora, who is actually on the call. Marco's been a wonderful addition to our team. We also have a technology lead through Chad Lee and UI consultants, and we are doing a lot of our software development through Farshore Partners. Okay, I think I might have got there in under 5 minutes, so please, questions, comments? We'll stop share. And Marco on the call with me there. Great.
So
All right. Go ahead, Dr. Polo.
Ladies first. I'll wait.
I don't have a question. I was just inviting everyone to the stage and you beat me to it. So you go ahead.
Okay. So if I understand correctly, and maybe I missed this, but it sounds like your solution is really a direct-to-consumer based solution. Okay.
Yep.
And are you envisioning that it could potentially be a digital therapeutic, you know, a prescriptive therapeutic with evidence behind it that it actually improves something?
Yes, yes, that is really where we are headed with regard to our service. We probably need more large-scale clinical trial data to receive the FDA approval for a digital therapeutic, but I think we definitely have the rationale for moving in that direction.
Okay, so with that in mind, that's what I thought you were going to say. With that in mind, what's your strategy to engage carriers and payers? Where do they come into the picture?
Yeah, so our strategy is that we think we have a solution that could save payers tremendous amounts of money, you know, for example, and also provide excellent service. So if only one of our, if we keep one person out of the inpatient unit out of 100 people who use Step Away, that would be a huge cost savings to an organization. So, so we are working on developing that relationship with large scale payers, with the idea that this is a solution that brings the service to large numbers of people and essentially can help to lower their cost by keeping people away from very expensive addiction treatment.
And maybe I'll add a little more that the solution today is a self-help tool, and it could be as well a companion app, in addition to empowering the patient to exercise abstinence or moderation. It's an augmented solution to prescribed medication, with the objective being to lessen medication taking and increase CBT self-help tools. So part of the roadmap, as Patrick is alluding to, is to go to the next level where we're going to introduce artificial intelligence to detect certain things and help communicate things directly with the user. But then the third tier is then also connected to a network of counselors and psychologists that for those patients who need that third layer of support beyond the self-help capability. And there's one thing I just want to add real quick in terms of the conversations that I've heard and the questions with regards to sort of the telepsychology aspect, because Dr. Polo, you made that comment, and I think as well, John, you know, with primary care, we've seen this over the last couple of years where the state barriers have been removed in terms of licensing, credentialing for cloud physicians to practice via telehealth platforms. But with telepsychiatry, psychology, we're still not there. And there's questions, in fact, when we met with the policymakers part of the 5 points of healthcare. We asked these questions. What do we need to know to learn more about where this is going, how policymakers are going to enable psychologists to be over telehealth platforms? I did learn that there is a pact called the Psy Pact that certain states are signing into. Sort of a, I don't know if this is a legislative bill, but it's obviously starting. We're starting to see some of that. And that's our hope, is that when we connect this with the psychologist, it would become a telepsychology platform that's able to perform cross states.
A quick question for you, Patrick. How do you rank yourself on one scale of 1 to 10 on cultural competence and cultural humility in terms of how this presents to your end users?
I would give us a solid 8. Just because 10 is a really hard number to reach, but we are really focused in on providing service to people, for instance, in rural areas. And I think our solution is very well adapted to reaching rural populations. We also are very careful about the language in the app and couching the language at a very good readable level, so that many different people can engage with the app.
One little thing, little add-on, just from the first question that you had, Dr. Polo, is that our strategy eventually will take us to talking to the payers, but first we want to work with those employers who want to add this tool as a benefit to their EAP program, right? A lot of employees from several types of employers would benefit from such a solution. And so starting, taking steps to get to that payer conversation, building additional stories that when we do meet with the payer, we have a bigger oomph to present with efficacy data and additional feature sets that would be then implemented due to the feedback that we get from these employers that do have also a dashboard.
Yeah, I'll just highlight that. Thank you for saying that. There's no question that employers are focused on trying to address their needs from a behavioral health perspective, because for them, it's all about productivity. Yep. And they have to make a critical decision, what's worth paying for directly out of their operational funding versus what is going to go to the health plan. And so you need to think about how to negotiate that strategically, because somebody has to pay for it in the end.
Exactly, the subsidization aspect of it. Yep.
Well, one of the things about our solution is that there is an obvious connection between, for instance, health problems and work-related problems that stem from alcohol addiction. So I think we have a good arguing points about how our solution can help reduce costs. Julie.
Yeah, I think I missed this, but we're talking about augmenting with match and the trajectory. Can you just re-clarify what is the product versus services right now, and where you see, how do you see that shifting, and whether you expect to be going into kind of an actual services model, or whether it will exclusively stay scalable tech?
Well, we've been really focused on scalable tech at this point. And in our roadmap, we would like to include other practitioners in the service. For example, having a connection with a primary care provider so that the provider can monitor how the participant is doing over time, and perhaps even to make a call if they get an alert from us that their participant is getting worse, for instance.
And when, if you're going in with either a payer or an employer model, have a sense of how that might happen, since there will be no relationship directly with the provider? Would that solely be initiated by the user?
Yes, that's okay. So that would be a great, so our vision is that we develop organizational models for each organization. We actually have that developed now so that the organization can be monitoring the particular participants as they're using it. And somebody at the organization could be able to see, oh, Mr. Jones is not improving, or he's getting worse, or Mrs. Smith has stopped using the system altogether. So really we're oriented towards a combined approach with providers and the individual using the app.
Gotcha. I'll just throw out, having worked a lot of employer wellness spaces. It's a big, privacy is a very big concern, and any perception that an employer is monitoring what your treatment levels are, or especially flagging that someone might need extra treatment, huge risk factors. So totally going towards payer models, integrating into providers, definitely those directions. That kind of population health tracking will make a lot of sense. But an employer model, you would need to employ those service providers. It would need to happen completely separate from the employer.
Yep, that's a great point, and it's come up in our discussions with employers as well.
I can imagine.
I think our employees would really want us to be monitoring them. And our solution there, at this point, is we wouldn't be providing for employers specific identifiable data to avoid that particular problem, because one of the big advantages of our solution is privacy. And that's something that people really like about our solution, is that it is focused on them. It is not shared with anybody unless they want it to be. And I think that is something we're really focused on maintaining, is a high level of privacy and confidence. And I think people would feel a little differently if the information was being looked at or accessed by their provider or by their mental health practitioner.
Okay, we are at time. So thank you, Patrick and Marco, for your presentation and answers. Judges, I'll give you just a couple minutes to enter scores, and we will then tally them. So audience members, just hold tight for a couple of minutes, and we'll be right back with the announcement of our grand prize winner. Okay, well, we are ready to announce our grand prize winner. This is it's so quiet. I'm just here in my office by myself, but I would like to invite Rose Health to the stage as our grand prize winner. So Matthew and Coffee, please join me on stage. And congratulations. You're the
Thank you,
winner
Laura.
of the
Thank you,
trails
guys.
competition.
Thank you, Laura. It's been a great ride on this trail.
Love it.
Yeah,
It's been-
and we just wanted to thank all of you guys for the feedback over the time that we've been doing this, and also to the judges for the great questions. We really feel like and hope that you guys get what we're trying to do, and we're going to keep working on it.
Yep.
Fantastic. Well, we thank you all for participating and congratulations to both of you. I'll be connecting you with Providence and Multicare in the next couple of days to begin the process of sorting out that grand prize package. And thank you all to the audience members for joining today. Thank you again to all of our judges for taking time out of your schedules to join and help provide feedback and questions throughout the event today. We have recorded this competition and it will be posted on our website, and we'll be sharing a link with everyone today so that you will have access to that recording. So with that, thank you all for joining. Take care, and we'll see you soon.
Thank you, guys. Take care.
Thank you.
Thank you very much for everybody, all the presenters.